Imagine watching an infant who is just working so incredibly hard just to drink from a bottle. I mean, they're engaging so many muscles in this desperate, uncoordinated rhythm that they're actually burning more calories than the milk itself even provides.
Yeah, it's heartbreaking to watch, and it's incredibly exhausting for the child.
Right. Or, picture a teenager sitting in your living room who understands every single nuance of a joke you just told. They
Yeah.
feel the humor, they want to join in, but they're physically locked out of the motor pathways required to laugh out loud or even just speak their mind.
It's just an incredibly stark contrast, isn't it, between their internal capability and their external physical limitation.
It really is.
And that contrast, I mean, that is the defining daily reality for families navigating this condition.
Exactly. So welcome to the deep dive. Our mission today is highly specific and honestly is deeply personal. We are dedicating this entire exploration to you, the parents, the carers, and the families living with a diagnosis of PURA syndrome.
And if you're listening to this right now, your environment probably looks a bit different than you originally imagined when you first thought about having a kid.
Yeah, completely different. You might be sitting in a NICU right now next to a tangle of wires. Or maybe you're in a living room that currently houses a customized wheelchair, a gait trainer, ankle braces, speech-generating tablets, and feeding pumps.
Right. And for a parent looking at that array of medical devices for the first time, I mean, the natural human response is often profound overwhelm.
Oh,
It
absolutely.
can trigger this really deep sense of grief because, culturally, we are conditioned to view these devices as symbols of confinement or defeat, like something went wrong.
I really want to address that feeling head on, actually, because it is entirely normal to see that equipment and feel like it's this visual confirmation of what your child cannot do.
Yeah, it feels like a spotlight on their limitations.
Exactly. But over the course of this deep dive, which, by the way, we're calling Equipment 101, from standards to specialist seating, we are going to systematically dismantle that perspective.
We really are. We're going to completely reframe this.
Right, we're going to look at the medical literature, the biology, and the lived experiences of hundreds of families. And we're going to see these devices not as crutches, but as the vital, liberating tools that they actually are.
They're literally the keys that give your child the freedom to safely engage with, explore, and communicate with the world.
Yes. And to build this new framework, we've synthesized a massive, comprehensive stack of source materials today.
We have.
Yeah.
We're analyzing the most up-to-date clinical characteristics from human disease gene databases, for starters.
And we're calling heavily from the comprehensive management guidelines published by the PURA Syndrome Foundation, right?
Right, which are essentially the gold standard for clinical care. We're also integrating the orphan anesthesia recommendations, which dictate surgical safety protocols.
That part is so important.
It really is. And we are looking at the latest natural history data stretching all the way through late 2024. This tracks the developmental trajectories of the more than 700 confirmed cases globally.
Over 700 cases across 60 different countries. It's a lot of data. But as we unpack all of this, I want you, the listener, to hold a specific analogy in your mind.
I love this analogy.
Yeah, so I want you to picture your child's brain, their unique personality, and their spirit as a brilliant, fully trained astronaut.
Okay.
They are eager, they are observant, and they really want to explore. But through a twist of genetics, they've landed on a planet with a tremendously heavy gravity well.
Right, a gravity well that you and I simply do not experience.
Exactly. Their body is fighting this crushing gravitational pull. So the equipment we are going to analyze today, the customized seating, the standards, the G-tubes, the eye-tracking screens, that equipment is their pressurized spacesuit.
It's the external framework they absolutely need to withstand that gravity, step out of the ship, and show you exactly who they are.
That's it. That analogy perfectly captures the mechanical reality of the condition.
It does. Because to truly understand why this extensive physical scaffolding is not just helpful, but medically mandatory, we have to start at the foundational biology.
We need to look at the root cause.
Right, which means going all the way down to the genetic code.
So let's start at the beginning of the timeline. Because the medical world hasn't actually known about this condition for very long, have they?
No, not at all. If a parent had a child with these exact symptoms, say, 20 years ago, the doctors wouldn't have known what to tell them.
What would they have diagnosed them with?
They likely would have received a generalized descriptive diagnosis rather than a definitive genetic one. Many older patients in the literature were initially misdiagnosed with severe cerebral palsy.
Oh, wow. Cerebral palsy.
Yeah, or atypical Rett syndrome,
Okay.
or They were just simply slapped with the label of profound generalized developmental delay.
Because the medical lexicon just didn't have a name for this specific cluster of symptoms yet.
Exactly. It wasn't until a landmark clinical paper published on October 23, 2014, by a team led by Dr. David Hunt, that PURA syndrome was officially recognized.
2014. I mean, that is literally yesterday in medical terms.
It really is.
So when the geneticists finally sequenced the DNA and found the culprit, what exactly were they looking at? Because the sources mentioned the 5q31.3 locus, which sounds less like biology and more like a coordinate on a star map.
That's a great way to put it because it acts very much like a map coordinate. So in the human genome, we have 46 chromosomes arranged in 23 pairs.
Right.
Chromosome 5 is one of the largest ones. The Q refers to the long arm of that chromosome, and 31.3 is the highly specific street address on that arm where the PRA gene resides.
Okay, so 5q31.3 is just the address.
Exactly. Now, in a typical scenario, a person has two perfectly functioning copies of the PRA gene 1 inherited from each parent. But in PRA syndrome, one of those copies has a variant.
Like a spelling mistake in the DNA?
Yes, a spelling mistake, or it's deleted entirely.
I notice the clinical literature consistently uses the term haploinsufficiency to describe this. Haplo, meaning half, insufficiency, meaning not enough.
You've got it.
But, so, if we have two genetic factory lines producing what the body needs, and one line shuts down or produces faulty material, why can't the other line just work double shifts to make up the difference?
Well, in many genetic scenarios, the body can actually compensate just like that, but the PURA gene is different.
Why is that?
Because the product it manufactures is in such incredibly high demand, particularly during fetal development and early infancy. One factory line running at 100% capacity simply cannot meet the daily quota.
Oh, I see. So the supply chain fundamentally falls short.
Exactly. And that shortage cascades through the entire developing nervous system.
So what is that product? What does the PRA gene actually build?
It provides the blueprint for a protein called Pur-alpha. This is what biologists call a highly conserved multifunctional protein.
Highly conserved, meaning
Yeah.
what exactly?
It means it's so fundamental to life that evolution hasn't changed its structure in millions of years. You find nearly identical versions of Pur-alpha in humans, mice, and even certain bacteria.
Wow. Okay. That is fundamental.
Right. And while it operates in the heart, muscle, and blood, its role is absolutely paramount in the central nervous system. The brain literally cannot wire itself properly without it.
The sources refer to Pur-alpha as a transcription activator. Let's break down what that means for the listener. How does this protein actually wire the brain?
Okay, imagine the DNA inside a brain cell as a massive, locked library of blueprints. A transcription activator like Pur-alpha is the librarian who holds the keys.
Okay, I like that. The librarian.
Right. It binds directly to specific sequences of DNA and RNA, turning other genes on or off. It regulates the proliferation of neural cells.
Meaning it tells brain cells when to divide and multiply.
Exactly. And it dictates the maturation of dendrites, which are the branch-like structures that neurons use to reach out and touch each other to form synaptic connections.
So it's literally building the physical bridges between brain cells.
It builds the bridges, and then it manages the cargo that crosses them. Pur-alpha is a major player in the transport of messenger RNA, or mRNA.
Okay, how did that work?
Well, neurons are incredibly long cells. The nucleus might be up in the brain, but the axon can stretch all the way down the spinal cord.
That's a long way for a microscopic cell.
It is. And if the synapse at the very end of that axon needs a specific protein to form a memory or learn a new motor skill, Pur-alpha binds to the mRNA instructions and physically transports them down the axon.
Down to the local site where the protein is actually synthesized.
Exactly.
Let me make sure I'm visualizing this correctly. We have a brain that is trying to develop, trying to learn how to move an arm or track an object with its eyes.
Right.
But because of haploinsufficiency, there aren't enough Pur-alpha librarians. The blueprints aren't getting read, the bridges between the neurons aren't growing thick enough, and the supply trains carrying the instructions are running at half capacity.
That is an excellent visualization, and it leads directly into another critical deficit we have to talk about. Myelination.
Myelin being the insulation, right?
Yes. Myelin is the fatty, protective sheath that wraps around nerve fibers. If you think of nerves as copper wires transmitting electrical signals, myelin is the rubber insulation.
Okay. And Pur-alpha plays a role in that too.
A huge role. Pur-alpha is key to the formation of that insulation. Without adequate Pur-alpha, the myelin sheath is thin or delayed in its development.
So the electrical signals from the brain are not only delayed because the bridges are weak, but the signals themselves are actually leaking out of the wires because the insulation is faulty.
Exactly. The commands from mission control are degrading before they ever even reach the muscles.
Which brings us to the most universal and immediate clinical presentation of PURA syndrome, something that almost every parent listening to this has probably experienced.
Neonatal hypotonia.
Right. When these infants are born, over 95% of them present with severe low muscle tone. In clinical terms, they're often described as a floppy baby.
And this profound weakness frequently triggers an acute medical crisis right there in the delivery room or the NICU.
Now, the literature emphasizes a really critical distinction here. I want to spend some real time on this.
Yeah.
Because it fundamentally changes how a parent should look at physical therapy and equipment.
It's the most vital concept, honestly.
The sources stress that the hypotonia in PURA syndrome is central in origin, not peripheral. Can you untangle the biology of central versus peripheral weakness for us?
Absolutely. When we hear the words low muscle tone or weakness, our immediate intuitive assumption is that the problem lies within the muscle tissue itself.
Right, like the muscle is weak.
Exactly. That is peripheral hypotonia. You see this in conditions like spinal muscular atrophy or SMA or in muscular dystrophies.
Okay, so what's happening there?
In those conditions, the muscle fibers are physically degenerating or the peripheral nerve connecting directly to the muscle is dying. Deep tendon reflexes, like when a doctor taps your knee with a hammer, are usually completely absent because the local hardware is broken.
But PURA syndrome isn't a muscle disease.
Not at all. In PURA syndrome, the hypotonia is central. The origin of the weakness is entirely within the central nervous system, the brain and the spinal cord.
Wait, so the physical muscles in the child's arms, legs, and core are fundamentally fine?
They're completely healthy. They have the potential to contract just as strongly as anyone else's. We know this objectively because when neurologists test the deep tendon reflexes of infants with PURA syndrome, those reflexes are typically preserved.
The local loop from the knee to the spinal cord and back to the muscle works perfectly.
Exactly right.
Okay, I have to play devil's advocate here.
Mm.
Or at least ask the question that I know is screaming in the minds of parents when they first hear this diagnosis.
Go for it.
If the muscles are fundamentally healthy, why are we talking about wheelchairs? Why can't we just do intensive physical therapy?
That's the logical leap everyone makes.
Right, because if you take a healthy muscle to the gym and do enough reps, it gets stronger. Why can't we just build these kids up through sheer effort until they don't need the equipment?
Because building muscle and maintaining posture requires a neurological baseline that these children lack. Think about what your body is doing right now. You're sitting in a chair, presumably feeling quite relaxed.
Yeah, I'm not really trying very hard.
But neurologically, you are not off. Your brainstem is constantly automatically firing thousands of microsignals per second to the postural muscles in your core, your neck, and your back.
Okay, so it's happening without me thinking about it.
Yes, it is maintaining a baseline resting tension that keeps your spine upright against the downward pull of gravity. It is an automatic subconscious hum of electricity.
Like an idling engine. If I try to tip you over, I don't just push against dead weight. Your muscles are already primed and firing to resist me without you even having to consciously think about it.
Exactly. But in a child with PURA syndrome, that idling engine is turned off. The lack of myelin and the insufficient synaptic connections mean that the constant automatic neurological hum from the brainstem is severely diminished.
The signals just aren't making it through the faulty wiring. So for a child with PURA to simply sit up straight and hold their head steady, they can't rely on automatic reflexes. They have to consciously, intentionally send a massive, concentrated signal from their cerebral cortex down to those muscles.
It requires immense conscious cognitive effort because the central tone is so low, they are in a constant, exhausting, minute-by-minute fight against gravity.
Wow.
The persistent hypotonia becomes the foundational barrier to every gross motor milestone. Think about the energy required for you to hold a heavy plank position at the gym.
Oh, it'd be shaking in a minute.
Exactly. That is the level of effort a child with central hypotonia is exerting just to keep their torso from collapsing forward while sitting on a rug.
If they are using 100% of their battery power just to resist the physical weight of gravity, they have zero energy left over.
Zero.
If you are burning all your focus on keeping your head up, you can't simultaneously focus on learning a new word, tracking a toy with your eyes, or even trying to digest your food. You are in survival mode against gravity.
Which is the core justification for every piece of structural equipment we're talking about today. Without external structural support, The child exhausts their physiological
The
reserves.
physical therapy is still important, right?
Oh, physical therapy is incredibly important for maintaining joint flexibility and building intentional movement. But PT cannot permanently fix the missing myelin or the lack of automatic brainstem signaling. The equipment steps in to do the job the central nervous system cannot.
This is the paradigm shift right here. When you look at a stander or a specialized seat in your living room, you are not looking at a device that means your child is weak and you've given up.
Not at all.
You are looking at a machine designed to turn off the gravity well. You are giving them their battery power back.
That's a beautiful way to put it. By providing the external structure, you free up their internal energy so their brain can finally focus on engaging with the world.
With that understanding locked in, let's transition into the specific ways these children move through the world and the physical tools required to make it happen.
Looking at the clinical literature regarding the timeline of gross motor skills, we have to acknowledge a stark reality. Motor development in PURA syndrome is universally delayed.
And the trajectory is vastly different from neurotypical children. The data indicates that a significant portion, in fact, most children with PURA syndrome, do not achieve independent ambulation.
Right. They will require mobility assistance throughout their lives.
And for the minority who do eventually achieve independent walking, the timeline is highly variable. The sources note that this milestone can be reached anywhere from 22 months all the way up to 10 years of age.
Furthermore, even when independent walking is achieved, the underlying central weakness and the delayed myelination mean that balance and coordination remain lifelong challenges.
The gait is consistently described in the literature as wide-based and unsteady, right?
Yes. They have a high propensity for frequent falls. And this isn't a matter of them just needing more practice. Their sensory feedback loop and motor planning pathways are neurologically compromised.
Which is where the physical scaffolding becomes medically necessary, starting from the ground up. Let's look at the lower extremities. Ankle-foot orthoses, or AFOs.
These are very common.
For anyone unfamiliar, these are custom-molded plastic or carbon fiber braces that fit around the lower leg, the ankle, and the foot. Usually they slip completely inside a slightly oversized shoe.
Right.
How exactly do AFOs compensate for central hypotonia?
Well, remember that standing requires the ankle joint to be incredibly stable. In a neurotypical body, the muscles around the shin and the calf are constantly making micro-adjustments to keep the ankle locked and balanced.
Those automatic signals again?
Exactly. But because the central signals are weak in PURA syndrome, the ankle joint tends to collapse inward or outward, or the foot drops forward. The AFO provides a rigid external mechanical lock.
So the plastic is doing the work.
Yes. By wrapping tightly around the calf and the foot, the plastic brace bypasses the need for muscle tension. It transfers the weight-bearing load directly from the foot up the plastic and into the strong tibia bone of the lower leg.
It's like taking a wobbly tent pole and wrapping a stiff splint around the base. If the foundation is swaying, the entire structure above it, the knees, the hips, the spine, has to compensate, which burns even more energy.
Precisely. The AFOs secure the foundation.
But securing the ankle is only step one. To actually practice the complex mechanics of walking, the sources rely heavily on gait trainers and customized walkers.
And a gait trainer is fundamentally different from a standard walker you might buy at a pharmacy.
How so?
A gait trainer provides a comprehensive, durable medical framework that completely surrounds the child. It usually features a saddle or a pelvic harness to support their body weight, along with chest pumps and arm support.
Because the fear of falling is a massive neurological inhibitor, isn't it?
Huge. If a child's brain is constantly panicking about losing its balance, it cannot focus on the sequential motor planning required to actually take a step.
The gait trainer removes the danger of gravity. It supports their body weight, allowing the child's cerebral cortex to focus entirely on coordinating the reciprocal movements of the legs.
Moving the right foot, shifting weight, moving the left foot, it creates a safe zone for neural pathways to practice firing without the consequence of injury.
It's a mobile safety net. But mobility isn't purely about walking from point A to point B. For many individuals with PURA syndrome, a huge part of navigating the world is simply sitting up safely.
Which brings us to a massively important topic in the sources: customized seating systems.
The clinical guidelines make it explicitly clear that sitting properly in a specialized wheelchair is not just a comfort issue, and it's not just a transportation issue. It is an urgent medical necessity.
The necessity relates directly to the downstream consequences of chronic central hypotonia.
Okay, break that down for us.
When a child lacks the core strength to hold their spine perfectly straight against gravity, The skeletal system takes the brunt of the stress. Bones and joints are living tissue. They grow and shape themselves based on the physical forces applied to them.
So if they're slouching,
If a child with low tones sits slumped in a standard stroller or a regular chair day after day, gravity pulls their spine into an abnormal curve.
and the clinical data on this is really alarming. The sources indicate an extremely high prevalence of musculoskeletal complications. Approximately 48% of individuals with PURA syndrome develop progressive neuropathic scoliosis.
Almost half. It is a profound complication. And because it is neuropathic, meaning it's driven by the neurological lack of muscle support, it is often aggressively progressive during growth spurts.
That sounds incredibly painful over time.
Yeah.
And it's not just the spine, right?
No. Additionally, many individuals suffer from severe hip dysplasia. This is a relapsing subluxation, meaning the hip bone frequently pops partially or completely out of its socket.
Why does that happen so often?
Well, the hip socket deepens and forms correctly in early childhood due to the stress of normal weight bearing and standing. Without that constant downward force, the socket remains shallow, and the generalized joint laxity common in PURA allows the hip to dislocate easily.
We also see notes in the literature about bone health. Many individuals demonstrate low bone mineral density, leading to osteopenia.
Right. Part of this is nutritional, relating to vitamin D deficiencies, but a large part is mechanical. Bones need to be stressed by weight and movement to trigger the cells that build bone density.
If a child is sitting asymmetrically, their spine is slowly twisting, the vertebrae are growing into abnormal wedge shapes, their hips are shifting laterally out of alignment, and their bones remain fragile.
Which is exactly why a customized seating system is so crucial.
Let's describe what these actually look like, because these are highly engineered orthotic devices. They are not just canvas chairs with wheels.
No, not at all. A customized seating system is built specifically for the exact dimensions of the child's body. It features rigid lateral supports that press against the sides of the rib cage to keep the trunk centered.
And there are straps, right?
Yes, it utilizes specialized multi-point pelvic harnesses to lock the hips down into the back of the seat at a precise angle. That prevents the pelvis from tilting forward or sliding into a posterior tilt.
And the cushion.
The cushions are often custom molded to distribute pressure evenly and prevent skin breakdown.
Think of this seat as a customized exoskeleton. It is literally doing the skeletal work that the central nervous system refuses to do.
That's a great way to think about it.
And here is where the reframing gets incredibly powerful. By holding the spine in strict anatomical alignment, this exoskeleton is doing way more than just improving the child's posture so they sit up straight. It is actively preserving their internal organ function.
That is the critical bigger picture. When a progressive spinal curvature develops, it doesn't just alter the child's outward appearance. A severe scoliotic curve physically rotates and compresses the thoracic cavity.
It crushes the physical space the lungs need to expand during inhalation.
Exactly. Over time, untreated scoliosis leads to restrictive lung disease, meaning the child cannot pull in enough oxygen, which then stresses the heart.
Furthermore, if the torso is constantly slumped forward, the entire digestive tract is compressed. The stomach and intestines are squished.
And the sources note that severe constipation and gastroesophageal reflux are incredibly common in PURA syndrome anyway. Squishing the abdomen makes both of those conditions infinitely worse.
So by utilizing the customized seating system to maintain an upright, elongated spine, you are keeping the airway open.
You're allowing the diaphragm to drop fully for deep breaths and providing the digestive organs the physical room they need to process food.
The wheelchair is not a symbol of a child being confined.
No, not at all.
The wheelchair is the external armor that protects their lungs, their heart, and their digestion. It prevents irreversible bone deformities. It gives them physical mobility, yes, but more importantly, it secures their internal health.
It's foundational.
So we've essentially built this incredible interlocking structural foundation. The AFOs secure the base, the seating system takes over the job of fighting gravity, the spine is aligned, the lungs are expanding fully, and the pain of hip dislocation is mitigated.
Right, the body is supported.
Now, the child has all this surplus energy that used to be burned merely staying upright. What happens to that energy? It goes into their eyes, it goes into observing the room. They want to engage, they want to connect, and they want to participate in the life happening around them.
But here we hit the most profound roadblock of PURA syndrome, which leads us to a fascinating area of the source material, bridging the communication gap.
The clinical literature documents a phenomenon that is arguably the most fascinating and simultaneously the most frustrating aspect of the PURA phenotype. There is a massive, widely recognized discrepancy between a patient's receptive language and their expressive language.
Let's define those terms clearly for the listener. Receptive language is what the brain can intake, process, and understand. Expressive language is what the brain can output speaking, writing, or gesturing.
Exactly. And the vast majority of individuals with PURA syndrome are entirely non-speaking or functionally nonverbal throughout their entire lives.
They may never produce meaningful, articulated spoken words beyond occasional highly practiced short phrases or isolated vowel sounds.
However, the data from parents, speech-language pathologists, and neurologists consistently confirms that these children possess a surprisingly high level of cognitive understanding.
Their receptive language skills are remarkably intact relative to their motor deficits. They can follow simple instructions, understand complex multi-step commands, recognize humor, and process the emotional tone of a room.
I really want a listener to stop and put themselves in that mental space for a second. Imagine possessing a rich, vibrant internal life. You understand every word your family is saying. You know the punchline to the joke before it's delivered.
You know exactly what movie you want to watch, or that your left foot is itching, or that you don't want to eat mashed peas today.
But you are physically locked inside a body that refuses to execute the muscular choreography required to express a single one of those thoughts out loud. The level of internal frustration must be staggering.
It represents a profound neurological barrier. The Pur-alpha mutation and the resulting lack of myelination seem to disproportionately devastate the expressive motor pathways.
The circuitry for speech is just that complex.
It's incredibly complex. You need high-speed neural circuitry to coordinate the diaphragm, vocal cords, tongue, and lips. The mutation hits that hard while leaving the deeper cognitive and sensory processing centers relatively more preserved.
So the equipment we bring in to solve this problem isn't physical scaffolding for bones and joints. This equipment is a social bridge. It is a technological translator designed to bypass the broken motor pathways.
We group this technology under the umbrella term AAC, which stands for Augmentative and Alternative Communication.
And the clinical guidelines have a lot to say about this, right?
They stress that because traditional speech therapy alone is rarely sufficient to produce functional verbal speech in PURA syndrome, early and aggressive intervention with AAC is considered a critical standard of care.
And AAC is not a single device. It exists on a wide spectrum, ranging from low-tech, physical systems, to highly advanced computer-driven technology.
Let's walk through that spectrum, starting with the foundational low-tech options.
What does a non-electronic communication bridge look like?
Low-tech options do not require batteries, screens, or charging cables. This category includes manual signing systems, such as keyword sign.
How is that different from regular sign language?
Unlike full fluent American Sign Language, which requires immense fine motor dexterity, keyword sign uses simplified, gross motor gestures to highlight only the most important words in a sentence.
Okay, that makes sense. Less precise motor control needed.
Right. Low-tech also includes symbol-based touch boards and comprehensive picture communication books.
There is a fantastic account in the source materials from the family of a 7-year-old girl named Sarah that perfectly illustrates the impact of this. Her parents provided this quote. Sarah has great receptive language skills, but has been unable to say more than the occasional word. With therapists, she is now learning to express herself using a PODD communication book and an electronic communication device. She loves to use these devices.
The PODD book mentioned there, Pragmatic Organization Dynamic Display, is an incredibly ingenious low-tech tool.
How does it actually work?
It is a physical binder filled with pages of categorized symbols and words. It uses a branching logic system. For instance, the child points to a symbol for I want, and the communication partner turns to the specific page that lists options like food, play, or go somewhere.
Oh, that's brilliant.
By pointing sequentially, a child with limited fine motor skills can build complex, grammatically correct sentences to express their exact desires or feelings.
And as Sarah's parents noted, she loves it. She doesn't view it as a chore, she views it as empowerment. It gives her agency.
Exactly.
But what happens when a child wants to communicate faster, or perhaps they lack the physical ability to reliably point to a small square on a piece of paper? That takes us up the spectrum to high-tech AAC.
High-tech AAC involves electronic systems. The most common iteration today is a touchscreen tablet, often an iPad or a dedicated medical device running specialized, robust communication software.
The screen displays dynamic grids of vocabulary.
Yes, the child touches the symbols or types out words, and the device utilizes synthesized speech to talk out loud for them.
But the reality of PURA syndrome is that many of these individuals have such profound central hypotonia and poor fine motor coordination that accurately targeting and pressing a 1-inch button on a touchscreen is physically impossible.
Which is where the technology becomes truly revolutionary. For children with severe motor limitations who cannot use their hands but have intact visual tracking, meaning they can intentionally move their eyes to look at objects, we turn to advanced eye gaze technology.
Eye gaze technology is the kind of thing that sounds like science fiction until you actually see it working in a living room. How does the camera actually read the child's mind, so to speak?
It relies on highly precise infrared technology. A specialized camera mounted below the screen emits invisible infrared light, which bounces off the corneas of the child's eyes.
And it tracks that.
By tracking the exact angle of that reflection, the software calculates precisely where on the screen the child is looking, down to the millimeter.
And how do they click a button if they can't use a mouse or their finger?
They utilize what is called dwell time. The child simply fixes their gaze on a specific symbol on the screen. If they hold their stare on that symbol for a predetermined fraction of a second, say 8.8 seconds, the software registers that prolonged gaze as a deliberate selection and speaks the word.
It is staggering to contemplate. A child who cannot walk, who cannot effectively use their arms or hands, and who cannot vibrate their vocal cords to speak, can engage in a full, nuanced, back-and-forth conversation using nothing but the intentional, microscopic movements of their eyes.
It's unbelievable. It completely shatters our preconceived traditional notions of what the term nonverbal actually means.
There is a profoundly moving quote in the literature from the parent of a 14-year-old boy named Aiden that encapsulates this exact paradigm shift. The parent states, "I have learned from Aiden that being nonverbal is not the same thing as not being able to communicate, and being non-ambulatory does not prevent him from being independently mobile. We've learned new ways of being in the world with Aiden so that he can live life more fully."
New ways of being in the world. That single sentence is the philosophical core of why all this equipment exists.
It really is. The AAC device, whether it's a paper PODD book or an infrared eye tracker, is Aiden's voice. The customized wheelchair is his legs.
When we redefine nonverbal through this lens, we realize that fighting for an AAC device through insurance isn't just checking off a clinical speech therapy goal.
No, it is an act of rescuing the child's inner self. It is providing the key to unlock the cage, allowing their humor, their opinions, and their personality to finally step out into the room.
It's the most important thing you can do for their cognitive development.
But as beautiful and liberating as communication technology is, we have to transition to the harder reality of the daily medical grind. We have to discuss the equipment that nourishes and sustains the physical body at a biological level.
Because, frankly, these are the tools that often seem the most clinical, the most invasive, and the most terrifying to parents when they are first introduced.
You are referring to the intense reliance on feeding and respiratory equipment. For the vast majority of families facing PURA syndrome, this is not an abstract future concern. These interventions are frequently required right from the moment of birth in the neonatal period.
Let's address feeding first. For a neurotypical infant, feeding is instinctual. But the clinical data reveals that over 80% of children with PURA experience significant chronic feeding difficulties.
Why is the simple act of taking in calories such a massive, life-threatening hurdle in PURA syndrome?
The hurdle is a direct consequence of the central hypotonia we discussed earlier, specifically affecting the cranial nerves. The primary medical culprit is dysphagia, which is the clinical term for impaired swallowing.
When we swallow a sip of water, we don't even think about it. It just goes down. But biologically, what is actually happening in the throat that makes it so difficult for these infants?
Swallowing is arguably one of the most complex, highly coordinated reflex arcs in the human body. It requires the precise split-second timing of dozens of individual muscles in the jaw, the lips, the tongue, the pharynx, and the esophagus.
The famous suck, swallow, breathe cycle.
Exactly. An infant must suck the milk, hold it in their mouth, momentarily close off their airway so the milk doesn't go into their lungs, swallow the liquid down the esophagus, and then immediately reopen the airway to take a breath.
That's a lot of coordination.
It requires flawless neurological timing. Because of oromotor hypotonia, low central tone in the muscles of the face and throat, infants with PURA syndrome severely struggle to coordinate that cycle.
The signals from the brain telling the airway to close and the throat to squeeze are weak and delayed. This isn't just an inconvenience where a feeding takes an hour instead of 20 minutes. It is inherently acutely dangerous.
It is life-threatening because if the timing of the epiglottis, the flap that covers the windpipe, is off by even a fraction of a second, the fluid or pureed food bypasses the stomach and enters the trachea and the lungs. This is known as aspiration.
And the lungs are a sterile environment designed for air, not milk. When milk enters the lungs, it breeds bacteria rapidly, which leads to aspiration pneumonia.
A very serious, tissue-damaging lung infection that frequently lands these children back in the pediatric intensive care unit.
Furthermore, even if the child avoids severe aspiration, there is the sheer brutal caloric mathematics of the situation. Because their resting muscle tone is so low, simply attempting to suck, chew, and swallow requires a maximal, exhausting exertion of energy.
This goes back to our earlier point. The child might actually be burning more calories trying to extract the milk from the bottle than the volume of milk itself provides.
The act of eating puts them into a caloric deficit,
which inevitably leads to failure to thrive. The infant becomes lethargic, their weight plateaus or drops, and most critically, the developing brain is starved of the essential fats and nutrients it desperately needs to form whatever synaptic connections are possible.
To combat this starvation and prevent pneumonia, medical intervention becomes an absolute necessity. In the short term, usually in the NICU, this means a nasogastric or NG tube, a thin tube threaded through the nose, down the back of the throat, and directly into the stomach.
But NG tubes are temporary. They irritate the throat and can easily be pulled out. For chronic, long-term management, the clinical guidelines overwhelmingly point toward the surgical placement of a gastrostomy tube, or G-tube.
I want to pause here and speak directly to the parents listening. When a gastroenterologist sits you down and tells you that your child needs a G-tube permanently surgically placed into their abdomen, it is so incredibly common to feel a wave of failure.
It's a very heavy moment.
Feeding your baby is the most primal, foundational act of caregiving. It is how you bond. To be told that you must replace that intimate act with a sterile plastic tube, a medical pump, and a bag of formula feels devastating. It feels like you are giving up on normalcy.
But the clinical reality is the exact opposite. A G-tube is not a symbol of giving up. It is an active, aggressive, vital intervention.
It is a tool utilized to guarantee that the child receives the maximum caloric intake necessary for brain growth, completely eliminating the terrifying risk of pulmonary compromise and aspiration.
We need to reframe the G-tube.
Absolutely. I want you to think of a G-tube not as a medical device, but as a direct energy pipeline. Your child's neurological engine is constantly running in the red, just trying to chew and swallow. If they keep running in the red, the engine's going to stall out.
The pipeline bypasses the bottleneck. It takes all that pressure off their face and throat and delivers the premium fuel directly to the tank.
And you know what the source material and parent testimonials actually report once the G-tube surgery is healed and the pipeline is running?
They report a massive, life-altering reduction in stress, both for the child and for the entire family unit.
It radically changes the dynamic. It turns mealtimes from a dangerous hour-long medical struggle filled with choking, coughing, and crying back into a relaxed social experience.
You can still sit together at the dinner table. You can still bond. You can still offer them small, safe tastes of food for pleasure if the doctors allow it.
But the pipeline is quietly handling the heavy logistical lifting of caloric intake under their shirt, so you can go back to just being a family.
That preservation of energy is doubly critical because the child's body is very often fighting a simultaneous battle on the respiratory front. Breathing, much like swallowing, relies heavily on baseline muscle tone and consistent central neurological drive.
The sources outline extensive respiratory issues, noting high rates of apnea, especially in that critical first year of life. Over 50% of affected infants experience apneic events.
We need to break down the mechanics of central versus obstructive apneas because the literature notes that both types occur frequently in PURA syndrome.
Let's start with central apnea. What is that?
Central apnea is a direct manifestation of the haploinsufficiency in the brainstem. The brainstem houses the primary respiratory control centers, and Pur-alpha protein is normally highly expressed in those neurons.
So what happens during an apneic event?
In central apnea, the brain simply forgets to send the signal. The electrical impulse to the diaphragm just pauses. The child stops breathing not because their airway is blocked, but because the central command center momentarily goes offline.
The engine just skips a beat.
Exactly. Conversely, obstructive sleep apnea is a mechanical failure. It results directly from the severe hypertonia in the oropharyngeal area, the muscles of the tongue, soft palate, and throat.
Okay, so what's the mechanism there?
When a neurotypical child goes to sleep, those muscles relax, but they maintain enough tension to keep the airway open like a rigid pipe. When a child with PURA syndrome enters deep sleep and their muscles fully relax, the floppy tissues of the upper airway physically collapse inward under the negative pressure of inhalation, blocking the flow of air.
So it's a terrifying double bind. The brain forgets to initiate the breath, and the physical throat is too floppy to keep the breathing tube open when the breath actually happens.
Yes. In addition to apneas, the literature notes frequent episodes of hypoventilation breathing that is chronically abnormally slow or shallow, leading to a buildup of carbon dioxide in the blood.
Because of this dual threat, respiratory support equipment is often a staple in the child's bedroom. We're talking about machines like CPAP or BiPAP, which push continuous positive air pressure through a mask to literally stent the floppy airway open from the inside out.
We are also talking about nocturnal pulse oximeters that wrap around a toe to constantly monitor oxygen saturation, setting off an alarm if the brain forgets to breathe.
And in rare but severe cases outlined in the data, tracheostomies, a surgical opening in the neck to insert a direct breathing tube, bypassing the collapsing throat entirely.
And managing this fragile respiratory system brings us to a highly specific critical warning outlined in the orphan anesthesia guidelines. Whenever a child with PURA syndrome requires surgery, whether it's to place that G-tube, correct scoliosis, or perform a tracheostomy navigating anesthesia, requires extreme specialized caution.
Why is anesthesia so much more dangerous for these kids?
The orphan anesthesia guidelines specifically highlight that patients with PURA syndrome demonstrate a profound, exaggerated sensitivity to sedative medications, particularly opioids.
Oh, because their central nervous system is already depressed.
Exactly. Their central nervous system is already fundamentally depressed due to the genetic variant. When you introduce an opioid, which suppresses the respiratory drive even further, the compounding effect can be severe.
So what do the guidelines say to do?
The guidelines mandate reducing standard opioid doses by at least 50%, and they strictly require a minimum of 24 hours of continuous inpatient monitoring post-surgery due to the exceptionally high risk of delayed post-anesthetic apnea.
So parents must be fierce advocates, bringing these specific orphan anesthesia documents directly to the surgical team, because a general anesthesiologist might never have seen a PRA case before.
It's vital that the care team sees those guidelines.
It is an undeniably massive amount of medical management. But as we comb through the natural history data, there is a distinctly hopeful biological note regarding these severe respiratory crises.
Yes, the long-term data reveals a very encouraging trajectory. While the apneas and respiratory crises are incredibly severe in the beginning, often requiring mechanical ventilation or supplemental oxygen, they frequently show gradual, significant improvement or even complete resolution after the first year of life.
Why does it get better?
The clinical hypothesis is that the autonomic nervous system, specifically the brainstem, manages to mature and stabilize over time. The body slowly adapts to the haploinsufficiency, the signaling pathways find workarounds, and the central respiratory drive strengthens.
The child may actually outgrow the need for the oxygen tanks and the monitors.
Many of them do.
Which is an incredible testament to the resilience of the human body. So let's take a step back and look at the entire landscape we have covered today.
We've covered a lot.
We really have. When you stand in your living room and look at your child, you might see the plastic AFO braces encasing their lower legs. You see the massive, highly engineered, customized seating system locking their pelvis and spine into alignment.
You see the plastic button of the G-tube resting on their abdomen. You see the glowing screen of the eye gaze communication device mounted on a mechanical arm in front of their face. And perhaps you hear the hum of a CPAP machine waiting by their bed.
To the untrained eye, it looks like a disparate collection of heavy medical interventions. It looks overwhelming.
It does.
But it is not a random collection. It is an intricately designed, holistic support system where every single piece relies on the others. They work in perfect concert. The G-tube pipeline provides the dense, vital calories so the child has the physical energy required to tolerate standing in the gate trainer.
The customized seating system, acting as an exoskeleton, aligns the scoliotic spine so the lungs have the physical room to expand and take in deep breaths of oxygen.
That oxygen feeds the brain, giving the neurons the stamina to maintain focus. And that sustained focus allows the child to deliberately shift their eyes to the AAC screen, hold their gaze on an icon for exactly 0.8 seconds, and finally tell you the joke they've been holding inside all day.
Every single piece of equipment is a piece of interlocking armor. It is a system designed to protect their incredibly fragile biology while simultaneously amplifying their fierce, unbroken spirit.
The overarching conclusion drawn from all the clinical guidelines and parent data is clear. This equipment constitutes a fundamental toolkit for independence. Whether it is a rigid piece of plastic preventing a spinal deformity or an infrared camera unlocking a hidden inner voice, these tools are the ultimate enablers.
They are the mechanisms that allow a child with PURA syndrome to break free from the physiological gravity holding them down, enabling them to actively engage with their family, their peers, and their community.
They are absolutely not symbols of what your child cannot do. They are the exact opposite. They are the instruments of freedom.
I couldn't agree more.
And as we wrap up this deep dive, looking at this through the lens of empowerment raises a fascinating, forward-looking question. The first cohort of children officially diagnosed with PURA syndrome back when Dr. Hunt published his paper in 2014, they are now aging into their teenage years.
Right, they're growing up.
As they grow into adulthood, and as technology continues to advance at a staggering exponential pace, the very definition of what constitutes an independent life is rapidly evolving.
Think about the technological leap we have made just in the last 10 years regarding eye-tracking software, environmental controls, and artificial intelligence integration.
It's exponential. 10 years ago, eye gaze was clunky and required constant recalibration. Today, it can interface with smart home devices.
Exactly. With the rapid advancements in digital augmentation and brain-computer interfaces, we must pose a serious question. How might the severe physical limitations of PURA syndrome, the inability to walk, the inability to speak vocally, become largely irrelevant in a highly augmented, digitally integrated future?
That's a wild thought.
If a teenager with PURA syndrome can control their room's lighting, direct their wheelchair, attend a virtual classroom, and converse fluently through a neural or advanced eye-gaze interface, the lack of physical muscle tone ceases to be an absolute barrier to a fulfilling, self-directed life.
The equipment sitting in your living room today, the standers, the seats, the current iteration of tablets, is truly just the primitive beginning of unlocking their full, incredible potential.
It's just the start.
I love that perspective. The brilliant astronaut is just getting fitted for their first pressurized suit. The launch is still ahead. To all the parents, the carers, and the families listening to this special deep dive, we see you. We see the exhausting logistics. We see how incredibly hard you are working to advocate for this equipment, and we see the brilliant, capable children you are raising. Keep fighting for the tools they need. Keep exploring those new ways of being in the world. Until next time, keep diving deep.